You are now listening to MedEd Talks Cardiology, a Vindico Medical Education production. To view the CE information and claim credit, log into mededtalks.com and search Lipid Legends Season 2, or click the link in the notes section of this podcast. Now, here's your host, Dr. Underberg.
Hello, and welcome to the Lipid Legends podcast series. This continuing education series is supported by educational funding provided by Amgen, Arrowhead Pharmaceuticals, Inc., and Novartis Pharmaceuticals Corporation. I'm your host, Dr. James Underberg, a clinical assistant professor of medicine at the NYU School of Medicine and the NYU Center for the Prevention of Cardiovascular Disease. I'm the director of the Bellevue Hospital Lipid Clinic and past president of the National Lipid Association and the American Board of Clinical Lipidology, and current president of the foundation of the National Lipid Association. And I am honored today to be joined by a friend, colleague, and someone I also consider a mentor, Dr. Ann Carroll Goldberg, who is a professor of medicine at the Washington University School of Medicine, also a past president of the National Lipid Association and the foundation of the National Lipid Association, and also, I believe, the American Board of Clinical Lipidology. Anne, in addition, is a giant in the field of lipidology and familial hypercholesterolemia, actually all lipid disorders. She's also a awardee of the Virgil Brown Distinguished Lifetime Achievement Award, which is the highest award given by the National Lipid Association. So, Anne, thanks for joining me today.
Well, thanks, Jamie. Thanks for the kind introduction.
So in this Lipid Legends podcast series, I've had the honor to interview expert physicians and researchers on topics that are of current importance in the field of lipidology. So today we'll be focusing on discussing homozygous familial hypercholesterolemia and getting to know Dr. Goldberg a bit better as well. So to start us off, Anne, how did you end up in the field of endocrinology and lipidology, which is where you kind of share your time and expertise, so to speak?
I started liking endocrinology when I was a sophomore medical student and continued to like it throughout internal medicine residency, then did my fellowship here at WashU with Bill Dawday, and I started out in neuroendocrinology, decided that I was not interested in lab work, and ended up getting a job with Gus Schoenfeld, one of the real giants in the field of lipidology, who founded the Lipid Research Center at Washington University in 1972. So I joined him in 1983. He introduced me to a lot of people and to doing clinical trials. And there wasn't a lot in 1983 for lipids. There was cholestyramine and cholestyramine and niacin. And we started doing clinical trials with lovastatin in 1984. And that was the real game changer in terms of treating FH.
That's great. So I think from there, you just found your way down a pathway that's led us to where you are now. And with all of the things that you've done over the course of your career, and I've had the pleasure of listening to you delineate that in your acceptance speech at the Virgil Brown Award, what career achievement would you say you're most proud of?
You know, I would say that it's probably the 2011 NLA recommendations on familial hypercholesterolemia, which I was pleased to be the chairperson for and main editor for.
Right. And for those who don't know, this really has been the go-to standard for guidance here in the U.S. on familial hypercholesterolemia. So let's get to the topic at hand now, which is appropriately FH, but in particular, we're going to be focusing on homozygous familial hypercholesterolemia, which we know as a rare but critically important diagnosis to recognize in those patients who have this disorder. Can you just give us an overview on the key clinical features that at least should make someone think about this condition?
Well, I think that the first thing is probably the high LDL, and generally over 400 to 500 LDL untreated. People need to start thinking about homozygous FH. And then the presence of physical findings, early arcus corneae, early tendon xanthomas, and then planar xanthomas, the xanthomas that appear in the creases on the hands that are kind of slightly raised yellowish plaque-like things over the knees, sometimes over the buttocks. And you start seeing those in young kids, and they're bright yellow. And in most cases, sometimes not as yellow, they can be mistaken for other things. In young kids for molluscum contagiosum, but then it never goes away. And if you actually biopsied it, you find that these are full of cholesterol. So early physical findings, very high LDL. And the other thing is having parents with very high LDL, so heterozygous FH. Typically in both parents, although given the genetics of homozygous FH, it isn't necessarily the case.
Now you see adults and children, even though you're an adult endocrinologist and lipidologist, correct?
That is right. I started seeing kids, and when I first started in 83, there was no one else seeing kids with lipid disorders. So I've basically been seeing kids with FH ever since. I also took over the care of two brothers with homozygous FH at the time, prior to any really good treatment except for plasmapheresis. We didn't have LDL apheresis.
So how important is it to recognize this at an early age, given that you see these younger children and how aggressive you are in identifying these patients so they can be managed?
Well, it's critically important to find them early because they get early heart disease and early aortic stenosis. In fact, you can see coronary artery disease as early as 1.5 in children with very high LDLs, homozygous FH. But they start popping up with significant events in childhood and adolescence. And so finding them early is really important because you need to start treating them as soon as you find them.
Right. Yeah, it's so important. It's so important. And so once homozygous FH is suspected, you mentioned a bit about family screening and also the potential role of genetic testing. How do you work through that regarding the process? I'm curious.
I don't wait for genetic testing. I make the diagnosis on clinical grounds. And typically, it's the very high LDL. And in a child, LDLs at this range, once you're getting over 500, is most likely FH. There's almost nothing else that's going to look like this. And so basically what you have to do is you have to start then thinking about offering genetic testing. But in fact, treatment begins before you even do genetic testing. You have to start treating them aggressively. And I refer to pediatric cardiology because you need immediate evaluation for the presence of coronary disease. So usually this would be a CT angiogram, also echocardiogram to look for any evidence of aortic stenosis, and oftentimes carotid ultrasound to make sure there's no carotid disease.
So I think that's really a key point to drive home here is the aggressive nature of the early atherosclerotic disease in these patients. And I think maybe for folks who aren't comfortable seeing kids with this condition, the urgency of that, could you expand on it a little bit? Because I think a lot of people aren't used to doing that, especially in younger kids.
Right. You wouldn't think about, well, is this child going to have a heart attack? But in fact, when you start looking at cases, I was recently at a Family Heart Foundation program for people with homozygous FH. And their stories are pretty significant in that some of them started having symptoms of aortic stenosis in their teens. Some of them had heart attacks or needed bypass surgery in their teens. They'd lost all their relatives in many cases. And some of them had strokes. So you can't wait around because many of them will already have really significant coronary disease when you first see them. The diagnosis is often delayed. So people are not screening children, even though it is recommended that we have universal screening age 9 to 11 and starting at age 2 if there's a family history of hyperlipidemia. I have 2 cases where screening was delayed for at least 2 years in children.
Right. And again, this idea of identifying first-degree family members also, this concept of reverse cascade screening, where if you start with the kid, you can go out, but obviously if you see an adult, you want to screen their kids.
Right. I mean, you would go out. I mean, the one of the problems is that since people don't know they have FH to begin with, you get really tragic cases of families where both parents have heterozygous FH and one or more of the kids has homozygous FH, and they didn't have a clue that this was going to be a problem.
So once you've identified the patient or the patients, the family, which is often this familial means it's a family diagnosis, can you just walk us through the current treatment landscape? And both you and I have had I guess, the pleasure of living our careers through the development of these drugs. And sometimes I'm embarrassed to tell people what we used way back when. But if you could give us an idea of the progression of treatments and what we have available to us now, that would be great.
Right. So the first thing is to always start with statin, atezotamide, and see what kind of response there is within a very short time. Usually I would give this only about 4 to 6 weeks before trying to see. In patients who have a little bit of receptor activity, a little activity of the LDL receptor, you might get at least some responsiveness to statin and ezetimibe. The next step would be to try a PCSK9 inhibitor, which will work to some extent in some patients with some receptor activity, but will not work very well in patients who have no receptor activity. And you try this for really not very long, maybe 4 to 6 weeks. If there's not 15% drop or more in the LDL, you just abandon the PCSK9 inhibitor. The next step that I would usually use at this point would be evinacumab, especially in children. It is a once-a-month IV infusion. This is an ANGPTL3 inhibitor, and this works by bypassing LDL receptor pathway so that this actually works in people who have some receptor activity. And fortunately, it also works in people with no receptor activity. And in both cases, you get about a 50% drop in LDL. So now you have three to four drugs. Another possibility is lomidopide, which is somewhat more difficult in children, but definitely worth trying in some adults. This is an inhibitor of MTP, which helps load up VLDL with triglyceride and cholesterol in the liver. When you block that, you make much less VLDL and therefore less LDL. The problem is that it requires a very low-fat diet and supplementation with fat-soluble vitamins. The other possibility would be lipoprotein apheresis. You need a child to be at least 3 to 4 years old before you can do that. The problem with apheresis is that there are not as many centers around the country that would make it available to everyone, particularly people living in large states, remote areas, rural areas, because it can require a while. You need access. Most of my colleagues now use ports, and it requires about 2 to 3 hours of the procedure to remove LDL directly from the blood. It's also temporary, so you need to do it every 1 to 2 weeks. So we're now at 3 to 4 drugs, 5 drugs, procedure, all of which are possible. One other possibility is liver transplantation, but I would consider that to be really last resort because you're just substituting one disease for another when you do that. You basically end up with, having to suppress the immune system, which carries its own problems.
It's kind of amazing, though, when you think about this progression of options that we have. And there was a time when, if you thought about lowering LDL 50%, you would laugh because none of the drugs would work because these patients didn't have LDL receptors. So to actually believe you can aggressively achieve LDL if you're persistent means that you really, as you're pointing out, have to keep trying and have to keep trying quickly. I agree with you. There aren't a lot of apheresis centers, but often people don't even get it offered to them. So understanding all of this, if the diagnosis is clear, you've already been able to highlight some of the complexities of this condition. What do you think some of the barriers are that patients face, and how can we as clinicians help overcome them?
Well, I mean, I think the biggest barrier is just making the diagnosis and actually getting the cholesterol measured. One of my patients was treated for molluscum for 2 years, from 8 to 10, until the dermatologist figured it out, and her LDL was over 700. She got to me, and we have been progressively lowering her LDL. Another problem is that there are pediatricians, family practice people who don't want to do lipid panels in children, even point of care. They don't really think about screening, and this is actually probably one of the bigger problems. Another problem is finding somebody who actually knows about it, making the diagnosis, and then referring the patient to the right specialist. This is not something that most primary care doctors without some training in this are going to be able to do. People are afraid to put these kids on medication. I mean, first child, I see a child, start on, okay, we're going to go with rosuvastatin 20 milligrams, and then we're going to add ezetimibe, and then we'll see what the numbers are, and then we're going to start adding more meds.
I don't prescribe drugs for kids, but I often will collaborate with our pediatricians, and I find a lot of them are resistant to starting medication. So it can be a struggle. Any concerns about either the access and affordability for some of these medications, and then also this concept of all the other people involved in making sure these patients get cared for properly?
Right. I think it takes a village. One part of it is convincing the physicians, convincing the parents. And part of the way I do this is sort of go into the family history and go into what the problems are. Access, at least to statin and ezetimibe, is not as big a problem because they're generic. The main problem is that you're prescribing some of them off-label. And then you have to sort of say, yes, we're prescribing off-label because this is indicated in this situation for kids.
Right. But for the adults, they're not off-label, right?
Oh, no. For the adults, it's fine. And usually adolescents, it's not a big problem. It's when you're dealing with the younger kids. The thing that is going to be helpful is that there are now new diagnosis codes for FH. So there is a new code. Instead of just a general FH code, there's a code for heterozygous FH and a code for homozygous FH. So having a specific diagnosis code helps. The other issue with access is, well, you need a pediatric cardiologist because you have to find somebody for kids who is going to be doing the CT angiogram. Otherwise, you can have an adult cardiologist take care of your adults. I mean, part of the reason that I feel so strongly about it and am so aggressive at this point is that the first 2 patients I took care of probably were receptor null, pre-statin, pre-apheresis. Both of them died at age 19. One of them had an aortic valve replacement at age 11. So you have to have a sense of urgency.
I can tell you who all of my patients with HoFH are, because they're the ones I worry about every night. So I hear what you're saying. And also, I think sometimes even finding nutrition folks who are focused on this and understand it. We're lucky to be able to work with some great registered dietitian nutritionists at the National Lipid Association, but there aren't enough of them. And getting good access to nutritional counseling, both for the diet or for some of these medications like lamidopide, is key and important. So that leads us to what I always love to talk about. We've talked about where we are. We've talked about where we came from. Where are we going? I was hoping you could maybe talk about where we are with screening, with guidelines, and also maybe with some novel therapies or different pathways that are in development that give us future hope for these patients.
Well, from the standpoint of recommendations guidelines, we will be putting out our updated version of the NLA recommendations with a clearly delineated pathway, being written by Marina Kukul, who has been the first author on both of the European HoFH guidelines from 2014 and 2023. I don't know what the general guidelines are going to say about homozygous FH. I mean, it is rare disorder. I mean, I think probably lucky if it's mentioned, or mentioned saying requiring further work. FH wasn't even in the cholesterol guidelines until 2013. And I actually wrote most of that section in the full paper for the 2013 guidelines. I'm sure there will be something about FH. I just don't know how much is going to be mentioned about homozygous FH, except maybe to call it out as a special problem.
Yeah, there's a little bit about it in that 2022 ACC expert decision pathway, but it's not really robust. It's just a series of algorithms that one can choose to follow. And we've had a lot of new data since then about drugs that are available to treat this condition. Is there anything else out there, novel therapy-wise, that's exciting to you in the field?
Well, evinacumab is a monoclonal antibody, and it works well. There's the siRNA technology is really coming up and coming for a number of things, and so the ANGPTL3 as a target of an siRNA is in development. Other things that are in development, for example, obicetrapib, which it may work through the LDL receptor. So I'm not sure how well it will work in homozygous FH. It's maybe another thing that might be helpful.
What about gene therapy? Any thoughts about where that's going? That's the buzzword everyone always likes to ask about.
Right. So the gene therapy is definitely in development, and the targets I think are PCSK9, ANGPTL3. The first study, the VERVE-1 study, used a particle that actually relied on LDL receptors for uptake. So in further development in the CRISPR technology, other ways of delivering it to the liver are going to be important. I think the big problem with that is it's going to take a while to get approval. Mostly because there's still issues. I still have a little concern about, what those pieces, what that editing is going to do to some other random sequence somewhere in the genome that could be a problem. And so the in silico work on it involves millions of looks at different places where the particular sequence could be. But I still think that it's going to probably take a bit of doing to get it approved.
Right. It's so appealing to think that one could do a single intervention early in life and be free of this disorder for the remainder. But as you point out, the difficulties in assessing safety and long-term efficacy in a space that's often been clouded with, some issues, I think make this something long-term and not something around the corner is what I'm getting from you. I think part of what I'm taking away from you is that we've got a lot of great tools available to us now. It's really recognizing, diagnosing, and getting these patients to someone who can treat them. So if you were going to kind of just summarize briefly for a resident or a student or a fellow of yours, what would you say are the key kind of points you'd want them to take away and understand from this?
Number one, cascade testing. That is, if you encounter somebody with very high LDL levels, then you need to make sure that everybody in your family has been tested, particularly where you have a situation where consanguinity or founder effect, is likely. So the big groups are French-Canadian Francophone populations that throughout Quebec and New England, actually, the Lebanese Christian population, and so a number of areas with FH in the Middle East, South African populations, Northern European Jewish populations are some of the major ones. I encountered some people recently where there's a significant amount of consanguinity, particularly in relatively small remote villages in places like Afghanistan and Pakistan. Other groups in areas like Romania, all over Europe, essentially. So there are people everywhere. You just have to find them. Given the prevalence of heterozygous FH is 1 in 250 to 300 people, we're looking at about 1 in 300,000 for homozygous FH. And so while it's quite rare, it's not vanishingly rare, and people need to think about it.
I always say that these patients aren't seeing us enough, right?
They are out there. The next problem is finding somebody to treat them, getting them plugged in to treatment. It is a difficult problem in places that are somewhat remote, especially where there are a few hospitals now. The Upper Peninsula of Michigan comes to mind as I talk to one person. And then starting with a therapy, overcoming resistance to treatment, making sure they get some testing for cardiovascular things. And then, I think that, what the current thing that's working the best on top of statin and ezetimibe and PCSK9 is evinacumab. And that's still an issue because getting it paid for, getting the arrangement made, getting the infusion done, insurance is still a big problem.
Although I have found that for these rare disorders, if you can make the diagnosis properly, sometimes it's easier to get stuff covered than more common issues that, they potentially have a greater number of patients exposed to. So this has been an amazing discussion. I just want to summarize briefly. We heard from a leader in the space, Dr. Ann Goldberg, about her career in endocrinology and lipidology. And for many of us who do this, it's kind of circuitous and the path is winding, but ultimately finds us in a place that we try to help and manage patients with some of these rare and uncommon lipid disorders. Homozygous FH is uncommon. It's probably more common than we think it is, and it's being missed a lot is what I take away from what you've said. The key is identifying as soon as possible in children. And if it makes it to adulthood without treatment, being as aggressive as possible, both in treatment, but also what you pointed out is in the aggressive cardiovascular assessment of these patients, the need to look for underlying atherosclerosis or aortic valve disease. There's a multitude of available therapies now. I think accessing them or getting them to someone who can is what I'm taking away from what you left us with here. And also the importance of this cascade screening, both, I always say north, south, east, and west, but adults, kids, and siblings. We want to check them all. And I think overcoming some of these boundaries, barriers, both to access, affordability, and then kind of putting together this team or village as you spoke to. So I want to thank you, Dr. Goldberg, for this amazing discussion and for agreeing to do this and give us your time. And thanks to our audience for listening. Please remember to take the post-test and the evaluation to receive your CME credit. And also be sure to go back and listen to previous episodes within the series, as this is the last of our 6-episode series. In prior episodes, we discussed the importance of lowering LDL-C, the role of LPA, and a variety of other topics of interest within the field of clinical lipidology. Thank you very much.
Thanks again for listening to MedEdTalks Cardiology. CE credit can be claimed through mededtalks.com. For other episodes in this series, search for Lipid Legends Season 2.